Okay, I think we are live. So, good afternoon, everyone. Welcome to the November meeting for the Durham Opioid Settlement Advisory Committee. My name is Shalisa Howard Martinez, and I'm serving as co-chair with the committee along with Brittany Price. Before we get started, I think it might be good for all of the committee members just to go around and introduce ourselves since we are still new and we're still getting to know one another. So, I'm going to go ahead and kick it to my co-chair, Brittany, to introduce herself.
Hi y'all, my name is Brittany. I use she, her pronouns. Obviously, I live here in Durham County. I live in Durham proper. And my work in my professional life is as like a technical assistance provider for harm reduction programs and related like state level and county health department programs, but primarily around monitoring and evaluation support for community-based organizations. And I'll kick it over to Karen.
Hey everybody, I'm Karen Kelly. I am the Chief Program Officer at TROSA, which is a long-term residential drug treatment program that is offered at no cost. And I'll kick it to Paul.
Thank you, Karen, and good evening, everybody. Good to see you all. Paul Nagy. I'm at Duke in the Department of Psychiatry and winding up a 40 plus year career as involved in the addictions treatment field, more broadly, I'll just say. And so I'm in the process of transitioning toward retirement, but obviously still an active advocate for the cause. And I guess Commissioner Jacob, I believe hi.
– Congratulations, Paul.
Thank you.
40 years. Wow. I'm Wendy Jacobs. I'm a Durham County Commissioner and glad to be with everyone.
Wendy, will you pass it to someone else, another committee member?
Yes, thank you. Sorry, I'll pass it to Jamie Carter.
Thank you.
Hi, everyone. I'm a primary care doctor and addiction medicine doctor at Lincoln Community Health Center. I do a lot of buprenorphine treatment in particular there. And I will pass it to Dawn Baxton.
Hello, everyone. I am Dawn Baxton, and I am the Chief Public Defender for Durham County. And I'm not sure who has it or has gone.
Okay.
And then sorry. My fingers would not move the mouse around. Good afternoon. My name is Kay Sanford. I'm assuming we are supposed to be doing something clever. Oh, hold on a minute. It vanished again. There, I'm here. And I am what are we doing? Introducing ourselves. I am a harm reductionist. I practice and advocate, and I've been working on overdose prevention since 2000. So we're ready to go.
Okay, and let's see. Is Lofton or Alonzo here? I don't think so. Is that everyone who's a committee member? Okay, all right. Thank you all so much for the introductions. So now let's go ahead and review the meeting minutes from our last time together in October, and we'll see if we need any corrections or additions. Jason, is it possible to show them, or if not, I can probably pull them up.
Sure, not a problem at all. You might give me 1 second. I can snag it in just 1 sec.
And also, Jason, you should probably introduce yourself as well.
Absolutely. My name is Jason Smith. I work for Durham County. I have the privilege of serving as the opioid settlement manager and working with this fine team. So looking forward to tonight. Let me grab the minutes for, y'all. Sorry, guys. You know how many photos I have to click through just to get to the get through there. All right, so here is November's meeting minutes. Sorry.
Okay, any needed corrections or questions about the November meeting minutes?
I think I have one correction, which is I don't believe I was a candidate for the co-chair. I think so
Okay,
that's a correction.
thank you. Thank you, Karen. Any others? If not, can we someone call for the minutes to be a motion for the minutes to be approved?
Motion for the minutes to be approved.
I'll second that motion.
Thank you, Karen. All committee members in favor of approving the minutes, say aye or just raise your hand via Zoom. Aye
Aye.
Aye.
or thumbs up. Okay. Thank you. Thank you so much, everyone. So next we have a presentation of the opioid settlement data dashboard by John Paul with the Durham County Department of Public Health. So John Paul, I'm going to go ahead and turn it over to you.
Hi, hello. My name is John Paul Zitta. I'm the data scientist in public health. I've been with there since 2021 and been with the county since 2016. I'm going to share my screen. I'm going to go through a few of the resources that have been generated of what we've been working on, and I really want to engage you all after I've done presented of maybe some ideas or thoughts how you'd like to move the data forward as a group, what you're looking for that we may not have, or certain avenues to kind of help us incorporate more useful data for making insights and decisions. So I'll show you what we have currently and what I offer maybe a suggestion or two of where we could potentially move, but really just trying to engage you all. So I'm going to share my screen right now. So first, before I get into the dashboard, I do want to share this awesome SUD resource guide. There's been a lot of really great work that's gone into this. I actually took the idea from Lacey Schofield and some others that have been really working really hard on this. And they had this SUD resource guide from 2024, and it was online, and it was nice and it was engaging. And I thought, well, how about we make that a interactive a map where any person can use this information? So all of this data, this image in the background, the language here is all written by Lacey and or her team. So as you enter this, you can see that there's navigating the SUD resource guide, and it shows you what the legend looks like. It kind of helps you navigate what you're doing and how you're utilizing this resource. And then what you can do is you can change the language right here as well, and you can see what happens on how to interact with the legend. So I'm going to go ahead and just show you what it looks like whenever you click anywhere. If you're looking for a specific location or type, you can go ahead and indicate that through your legend down here at the bottom. And you can kind of see what you're looking for if you're looking for a specific thing. If you're right here right now, you click that location and it populates right here. If you want to look at within a mile radius, it draws that one circle, mile radius, and it populates that information. The data that was available on the ICD resource guide gave you, information about where you could go to it, if there was any notes associated with the location, what it offered. For in particular, South Life Healthcare in this instance is peer support. There's a website. You can click the call. If I hit that, it will call and using Skype with Business, which I don't actually have on my computer, which is kind of funny. You click here, it will navigate you to Google Maps, and it will show you from your location to here, and it tells me it takes me roughly about 3 minutes or so if I needed to leave there. You can also open a website if that location that you clicked on has something that is a resource, that is a website. You can also just copy the link to results and you can look at that. If you're looking for specific things, if you're looking for an MAT site or a counseling, therapy counseling, you can also leverage that. If you're not quite finding what you're wanting to look within your radius, you can expand that a little bit, and we'll click through again and we'll go, okay, let's go 2 miles from here, and it expands again. Low. There we go. And there we go. So it shows all of that information, and it shows us within that 2 mile radius all the locations, and there's 34 results. But again, it follows the same pattern of if you're looking for shelter and housing, there's a very easy specific location that it tells you Urban Ministries of Durham to call, the website, the Google Maps, and then a note. It's telling you to call this location, to call this number first. So this is just a resource that we have available. There's an excellent PDF available already, but I will share this map for this resource guide for everyone, and they can kind of navigate it at their own volition or however they like. But this is just something Jason and I have talked about. We meet once a month and we kind of brainstorm about new ideas and how to leverage and uplift already existing work, and trying to integrate new things to make life a little bit easier for everyone doing this incredible work. To go through the dashboard, this is available as well online. I just updated it. I update it about once a week. It's mostly automated at this point, to where I just kind of oversight and make sure that everything is kind of being integrated correctly. The numbers are coalescing. I'm not having errant zeros or any errant numbers overall that kind of just throw off our data set. So this is our vending machine data that talks about strictly at the two facilities that we manage. There's a third coming online, and once we get that data is actually going to be pretty cool, because that one's going to be shared with us digitally, and it's going to be shared with us actually quite frequently. So there'll be a lot less overhead that I have to manage on that, but we'll make sure to integrate this here, and then we'll probably have a map once we get that all set up on the pinpointing of the locations for where these specific vending machines are going to be, because there is anticipation that there will be more than just the third. So there are filters right here on the left-hand side for most of these. If you're looking for that, you can see when the data was last updated, which was about 3 p.m. this afternoon, 2:53, however. And you can click on if you want to look at specific quarters, and you can kind of see how all of that data works out. You can see that it's in the traditional calendar year breakdown of quarter for how it goes, and you can kind of see what the sums are by month. The data was updated today, as I just mentioned, for this data set, so there is some data for December if available. Navigating through, you can go to trend data, and you can see the dispersal in relation to the last quarter of the last year. So we're looking at the Q2, which is our last complete quarter, and we can see for the PH vending machine, there was an increase of around 40% versus Q2 of the last fiscal year. So thinking about it from just a slight comparison, because we don't have a whole lot of data to make a bunch of comparisons. But once we get a little bit more but I do want to brag on the team that is actually keeping this data up to date. The harm reduction team in Durham County Public Health is doing an excellent job. They keep this up to date, and they've really integrated and kind of made this into their daily practices. And so we're really getting a lot more data points more frequently, which is really awesome. The vending machines are staying full. They're inviting by staying full, because we have noticed whenever we first started doing this, when they were more empty because we didn't have enough supplies, that maybe people felt a little less inclined to actually engage with the vending machine. But now that they're constantly full, overall, we have seen better dispersal rates. So that's awesome. The ultimate goal of this particular line chart is to actually do some forecasting and then seeing our actuals versus our forecasting. But we're not quite there yet because there's still quite a bit of anomaly in the data. But since we've been collecting it more frequently, we've actually been able to see better overall counts and kind of really see our dispersal, because we're collecting this data 2 to 3 times a week, which is awesome. The vending machine at the sheriff office, I think, just kind of has its own set of circumstances that makes it a little bit more complicated to acquiesce, but there is still constant checking by the team internally. But still, we can see that there is a little bit less overall dispersal. So this right here, I've kind of removed some of these charts, and I'm still working through this. I think that there's a lot of data that can be navigated here. I only have the 3 months of the first set of from this fiscal year kind of selected to kind of show what we're doing here. As we're working through this, I'm trying to navigate how we better communicate and translate some of this data for all of the hard work that's done through naloxone and the harm reduction. And then we move over to our harm reduction for syringes, and we're kind of seeing that the disparate information, and we're seeing the breakdown through the past 25 years. I mean, the past 25 years, through the past year, starting in July, and we can kind of see that coalescing through November. And you can kind of see it. It's a little wonky in how it's displayed, but it's because of the way the fiscal year is kind of shifting that information. So there are some minor adjustments that need to be made to these things. Then we have the next one, that is naloxone distribution by zip code, which shows a map, and Narcan distribution, and it shows by the zip code where the data has been distributed, as we're constantly working through all of these things. Then we go to recovery support services, and there's actually an incredible amount of work being done with recovery support services. We have a lot of just different data from elected demographics, the appointment types, the total number of contacts the program had, the total number of patient therapy linkages, and the participants and the programs with a referral. So the next thing that I'm thinking about for incorporating this is kind of making it similar to what we have internally, which is showing the data kind of like this, showing our records from this time frame with the subtext, showing the peers that assist with housing, showing the percentage of baseline outpatient therapy, and just showing this data as a percent of total record. So that's something that I've been thinking about. I just have not had the time to integrate into this dashboard, but I do plan to have some widgets that kind of show some of the KPIs that I just showed you right here, communicating like the total percent of records based off of the patients that we've seen. RSS assistance is showing the recovery support assistance, which is kind of showing additional data points that for all of the hard work that they do, did the peer attend the outpatient therapy session with the guest? Yes, no, kind of just showing the overall breakdown of how that data is working and how it's looking. Then we move on to the EMS data, and we can see the EMS demographics. We have the incident data count. All of this data goes back to March 1st, 2025, because that is when the MOU was signed, and so that is the beginning of this data set. I do not have a date, a selector or a filter for that, because that was not agreed upon in how we displayed the data, so we're just displaying all of the data. So maybe next year, whenever we rewrite our MOU to incorporate some of the MOUD data, that will be something that will be added into the emergency services. And we can maybe start showing that data by year or by quarter if possible. But again, for suppression and privacy, we have removed the ability to sub through the data in the process of looking at it by date. You can see was naloxone used more than once, and then we can kind of see yes, no, the age breakdown of the patients. We can kind of see the breakdown there as a percentage, male, female. We can also see hour of day that it was used, and typically more up and to the right, kind of showing a more later time frame, 0 being midnight, kind of cascading through the 24-hour clock. You can see roughly around 80% of all patients were transported to the ED, and the incident count is roughly 644. as we continue to navigate through this, as this data populates, you can kind of see the breakdown and the pop-up of our data by zip code. There is more granular data that we can look at, but as I mentioned, the data set is still relatively small. So for suppression, I will not be sharing it in this live meeting. But if we want to have a private conversation where we look at the heat maps, I am all ears and all willing to do that. I just personally do not feel comfortable, and I'm not entirely sure of the legal ramifications. So for just safety reasons for myself, I am not going to be sharing the heat map, but I do have a heat map that's more granular, and it does show hotspots throughout the county in certain aspects and certain avenues that we could definitely digest and communicate and talk about approaches into how we display this data for the public if we decide to do so, or how we decide to leverage it internally.
John Paul,
Yes, ma'am.
this is Kay. I
Okay.
was not listening carefully enough.
Okay.
What's your suppression point? How many?
Okay, so it kind of depends on exactly what you're looking for. So for survey data, I typically don't supply any data. I suppress data for like 10 or fewer, depending on HIPAA data. It's sometimes 100 or fewer. But I just was so unsure about this and how it was written in our MOU that I just veered on the side of caution.
That's great. One of the groups that I worked with many years ago that has, reasonably, I think, consistent approaches is NC Detect. And
Okay.
so you may want to get in touch with Anna Waller or some of their lovely, equally geeky people, and they have set up really good suppression criteria.
Okay.
So for us to be consistent with some of the other major databases in hospital discharge, emergency
Okay.
runs, this kind of thing, that might serve us well in the future.
Okay, I love that. Thank you so much for that. I honestly, I will reach out. I'll probably get an email out at some point. I do use NC Detect quite frequently. I've had communication with them before, so I really appreciate that insight, and I think that's an excellent idea. Moving forward, looking through the port data specifically, this is what Awesome Helen Tripp has been working on, and her group has been kind of engaging with. I just recently I changed this from a raw value to a percentage. I know that's like super minor and it doesn't really mean a whole lot, but it's a lot easier, I think, for sometimes to digest this. And I think as we're growing as a program and as we're leveraging our data and leveraging our efforts and kind of as I'm learning more about this, I'm kind of trying to figure out the best way to present a lot of this information, and raw counts for some of this just doesn't matter. I think it's a lot more impactful to look at it as a percentage. So I know that's a super minor thing, but I just did want to mention that like I am learning through all of this, and I think we're all learning through this and trying to be as transparent as possible, but also provide as much useful information as possible. So, something simple like changing a raw count to a percentage, it doesn't mean a lot internally, but it does mean a lot from like a growth standpoint. So again, the filter is on the left side. I just only have the most recent set of data. We typically wait till the end of the quarter before we collect the additional subsect of data because we typically report it out by quarter for suppression reasons. So moving through the toxicology data, talking about NC Detect and their awesome work, this is actually a replication of some of what they've done. Since I have direct access to the NC Detect database, I was able to actually provide this. I stripped all out all the PHI, and all I had was just what some of this information kind of shows from a higher level, just to provide a little bit more frequent data set, because it is difficult to access at times, to access those online PDFs that they provide, and the numbers, just aligning them perfectly, and they could be a couple months old before they get uploaded. Like I think the most recent one when I checked a couple days ago was August, and we're in December. So nothing wrong with what they're doing. They're awesome people, not criticizing, just providing a little bit of insight. So I essentially took their PDFs that they provided and just kind of replicated it as something that we can share and look at the overdoses as the easy visits. Then navigating through, same thing exactly from NC Detect, taking that data, replicating it, showing it the exact same way that they're showing it, and then showing the breakdown from the toxicology data for the positive death rates. But that data is a little bit more on to date, just because it takes a couple months, as you all know, with your expertise, that it takes a little bit of time to validate the cause and reason for death. Then something that we've added recently, which is awesome, is that we actually are very transparent with the opioid settlement funds and how they're being displayed and how they're being leveraged. So this is a Pareto chart or an 80-20 chart, if you've ever heard of it. Consistently 80% of your data is communicated by 20% of your categorical variables, and you can kind of see that. So you kind of see harm reduction constitutes about 32.5% of the 2025 fiscal year budget, and then you add in the peer support, and now you're up to 61% of your total, et cetera, et cetera. And you can kind of see in 2026, there's been a slight transitional change, a little bit less in the peer support from a total perspective, but it is still the most that we have and authorized. And then it kind of goes into harm reduction, and you can kind of see that progression, and then port as well. And so you're kind of seeing that transition and the change over time for how this works. And I think this is actually a really awesome way to display this data and kind of show all of the hard work and showing that things are changing as fund adjust and shift and our strategies adjust and shift. So that's all I have for you right now. Like I said, I do have a few other things, but I'm just not quite comfortable with sharing it at this moment in time. But I do have it, and I do want to display it and be as completely as transparent as possible. So that's all I have from a sharing perspective. The only thing that I was thinking about from like additional questions I had is, how do we move forward? What do we do moving forward? Do we want to start capturing data about wound care? Because I know that's something that's being leveraged and indicated. Is that something that we would think about maybe possibly doing? Are there any SUD issues that aren't being addressed that we could start collecting or collating that data? Are there already additional resources that some of our partners are collecting that maybe we could kind of help highlight? Because that's the whole intent and purpose of these dashboards and data outputs, is just to highlight all of the hard work that all of these people are doing. I'm not doing any of that hard work. I'm just kind of displaying it. Like, I just want to make sure that we're leveraging that appropriately. So that's all I have. I'll stop talking. I could go on forever. But yeah, nice to meet you all.
Thank you, John Paul. So I see Brittany and then Paul have questions or comments for you.
Yeah, thank you so much, John Paul. It is no small feat to create a data dashboard, and I really appreciate all of your hard work. I think I had a couple of questions, and just kind of like generally like notes on like language that we're using across these tools. So like, I'm curious about the units of the naloxone distributed. Like, are we talking about like my impression is that perhaps we're talking about boxes of Narcan, but I'm wondering if in the future, when we measure this, we could measure doses of naloxone distributed, because there are many forms of naloxone. We know that, like, I'm not sure that the county is currently distributing intramuscular, but we know that that's like largely preferred among people who use drugs. And so it would be great if we could at least set the stage for like different forms of naloxone in the future and just like measured by units. I am curious about like whether in the future it's possible on the map to I noticed that we said MAT, and like I just wanted to make a note that like in the like current parlance we say like medication for substance use disorder, or more specifically medication for opioid use disorder. And it would be so fantastic if we could differentiate among the types of MOUD that are offered at each place, because yeah, people like to know, what their options are. I'm curious about if we could change the language about like treatment in incarceration to treatment in jail, just to add specificity. And then I was curious about, like, I think on the port dashboard, we have the measure of like adherence to treatment. I'm curious about if we can change that language to like exactly what we mean. Like, do we mean who attended one visit, who were still engaged in treatment after 3 months, or like whatever that measure is, if we can just spell that out in that field. And thank you so much for listening to this long list.
Oh, no, that's excellent. That's exactly what I'm looking for. Thank you so much. If you don't mind, I'll supply you my email. If you could kind of put that in the list. I wrote down everything you said, but I want to make sure that I get it correct, because I completely understand and agree that language is important. How we communicate this is very important. So thank you for that, truly.
Thank you. Yeah, I'll send you an email.
And then Paul, and then Kay and Wendy.
Yeah, I concur with what Brittany said, John Paul. You did an awesome job with it. You're doing an awesome job with it. So thank you so much for your significant contribution. I had maybe two questions. One related to the dashboard and the language, stuff that Brittany brought up. You had under toxicology, you had a notation for commonly prescribed opioids, I think it was, or narcotics. And I guess the question I have is, does that mean those people in that data set, that those people had prescriptions? Because that's an important point, to understand whether or not people are actually abusing their prescribed pharmaceuticals versus they're buying it off the street. And I'm just wondering, is there a way to differentiate that? Because that really is, because one of the challenges we have in terms of our, in kind of the field is the idea that everyone who gets a prescription is going to be an abuser. And that's not the case. So I just wonder if there's another way to address commonly prescribed narcotics or opioid, whatever it was, opioid, I think. If that makes sense.
Absolutely. So that's actually I followed the exact language that was used from NC Detect, so I can follow up with them on if there's a specificity on how they do that or how they communicate that. But when I looked at the ICD data, it looked like that's how it was being coded. Was it just kind of said commonly prescribed? So there was no specification, but we can change the language or we can adjust how we approach that, or we can even remove it if we think that it kind of harms or needs to be adjusted or whatever. I'm
Yeah,
fine
because
with
the
it.
numbers were high, and my
Right.
concern is it's going to be inferred that people getting prescription drugs are in that data set, and I don't know that that's always actually, it's probably not the case most of the time, I'm guessing.
Okay.
My other question, and builds on something Brittany brought up, if there's a way to track kind of one, of the people, we talked about this last week with Helen, I think, of the people we do touch at least one time, to what extent do they convert into treatment, and also time and treatment. I mean, I don't know how capable we are of tracking people over time, but I think at least if we knew whether or not they were still engaged, we would probably be able to infer that those people were probably doing okay, and that, the fact they touched our system made a difference. Because just to say they entered doesn't mean that, because sustainability of effect is what we're after here in terms of outcomes. So I don't know how you get it, because you have to find some way to track the people you touch, and that requires some kind of resource to do that.
I love
So
that I love that you said that. That's actually one of the main components that we're working through in our MOU to actually be able to collate that data, especially with the MOUD data is seeing the longitudinal effect of actually of having those conversations. So I really appreciate that. Yeah, I'm glad that we're saying that. So yeah, I'll push that even harder, but that is something that I think is really important to capture too. Thank you.
thank you.
Kay?
Okay, let's see if I can actually get the system to work with me. One, John Paul, how do I love a computer geek? Let me count the ways. This is absolutely fabulous. And what I'm wondering is, when you started looking at Lacey's wonderful handout on resources, and then you went into what I would call stellar mode by having these on maps, so that someone can actually zoom into an area where they are, and they can get to these resources. I really believe is a quantum leap. And what I would like to suggest, if it's possible, that those resources, the map resources, be made available to those who need them most. So I would suggest that for all of the peer workers, they get trained on how to use that system, that the folks at the detention center and there we're talking about Cindy West, who works with the Star Women, and Tremaine Sawyer, who works with the men, and Lofton Wilson, who often teaches the men, that all of these folks get to know how to use this, and we figure out a way to make sure that those who are in the house, when they leave, know that that resource is available and how to use it. Handing out a pamphlet is lovely. It gets put in a back pocket or a paper bag and dumped someplace, even though I believe it's one of the coolest tools that we've put out. Nevertheless, if we teach them how to use something on the computer, their laptop, their cell phone, whatever, it will greatly enhance their ability to find and use these resources. I don't know what programs and policies exist, but if that's something that you can take under advisement, I think it would be a brilliant enhancement to what we're trying to do. Thank you.
Yeah, awesome. I think that's very awesome. I appreciate the kind words. Yeah, I do want to get this far and wide, and we've been working on it for a while. I do think the other major issue, at least in my opinion, and maybe it's not necessarily true with this, but whenever I publish web naps, one of the first thoughts I have is it's already out of date. Because the data just is constantly evolving. There's always new things. There's always places closing. There's new places opening. Talking about parking garages. Oh, I mean, just like all of the different things that I have to navigate through. So having a community that's helping and kind of engaging with you and helping you keep this information up to date is really empowering and impactful. And we've been working with that with our ACEs coordinator. We have, a publicly available resources where people can insert their own data for ACEs data, but it relates to this too, because now we can do it with the SUD resource guide. We can, oh, I know of this new place, or oh, this place is actually closed. Did you know that? No, I didn't. So, awesome information and information sharing. So I love that idea. That's very empowering, and I appreciate that. Thank you.
Wendy?
Thank you so much, John Paul. I had looked at your dashboard before the meeting, and I was really blown away. I would love it if you could really do a training for all the Durham County departments on how to do, creating these dashboards, but also how to be really measuring programs and outcomes, and then how we can share this out, because this is just one thing that we're doing in Durham County government, and you can see how important it is to be able to show have an interactive dashboard. What Kay just said was one of the things that I was going to say. I was wondering, how can we really activate the resource guide? I think all of Kay's suggestions were really good. And I would add the FIT program is another partner who helps people who transition, out of the jail. But obviously, everyone who's touching, people who are dealing with substance use disorder in one way or another really should be reached out to and trained. I mean, we have our recovery court folks. We've got the port team, peer support. I mean, there's just wherever people are being touched along the way. I think that training people on that would be great. I was wondering about, in terms of the dashboard, how do we dig into getting at some of the issues that we're seeing, some of the disparities and things? So one is, we know that we have a racial disparity with overdoses, and I've heard Dr. Wanda Boone say this, and that it seems that what's happening in the Black community is that people are taking medications, opioid medications, with alcohol. And that is like a theory right now around why the overdoses are higher. And I know that's something that, Durham Tri is working on, but is there a way to start zeroing in on trying to understand what is behind that disparity? And so I guess one thing would be if we could somehow have people who are collecting the data ask, did you take alcohol, with your medications or, so anyway, I'm just throwing that out there, but that's something that comes to mind. The other thing is what Paul was talking about is I know we've been trying to really dig in and understand better, like what keeps people from, they get connected with a peer support specialist or medication assisted treatment, understanding what the barriers are and why people may not continue with that treatment. And I don't know, it's really up to you all, people like Brittany, to get at like what are the questions that we might need to be asking or following up on. Another thing that I've heard when I ask people like Helen Tripp, I've heard her talk about stigma, that, and especially in the African American community, stigma. So I guess, just thinking about how do we use what are things that we need to be looking at to try to help us understand the problem so that we can, be more effective at stopping people from overdosing and getting them into treatment. So, and maybe other people I think on this in the group may have better ideas than me or ideas about what are the questions that we could be asking going forward. Thanks for your fantastic work.
Thank you. I appreciate that very much. Just one minor comment. We do actually, in the EMS data set, when I worked over there, we did ask a specific question about alcohol. So I know for a fact we could incorporate that in our data set. We'll just add that into our MOU and say, were you using alcohol? And so that's something that's very easy to integrate. And that is a majority of, I don't know the percentages, and I would love to know the direct percentage that we do see in EMS for the overdose total. That's something that I'm trying to investigate. If it's 80% or 60%, but to see like what the actual engagement with EMS of the total, I think is a really important caveat that I don't know the answer to, and I want to work towards it. But I think it would provide a lot of insight because our paramedics work so hard and they collect so much high quality information and they're so thorough that I just know that that would be a plethora of data to know the percentage base of the total. So of
and
reporting.
one fantastic, and one last thing around the heat maps, the thing, information that you didn't want to put out publicly, what comes to mind would be like how to share that or bring people together in person to look at that, like heart, the paramedics, people who are out in the community and having, or harm reduction folks, them being able to use that data.
Thank you. I appreciate you.
And Dr. Carter.
Hey, thank you so much for this great work. I agree that I think the map with the resources is really great, really helpful. I think I was just looking at some of the MOUD treatment sites, for example, and like Lincoln, where I work, it just I think it probably just has the main phone number listed. So it might be helpful to try to get like more specifics to put in the notes section about this is the specific number to call to try to get an appointment or how to reach out, and that maybe treatment is available for free or something like that from those providers in particular to put on the map. And I could help with gathering that information for like my site specifically, but maybe reaching out to others to get that information. And then I agree with Paul. I feel like the data on the opioid overdose ED visits is confusing, and you may, I think you're just getting that data from the data set that you said, but it doesn't seem like it makes sense to me that like the commonly prescribed opioids would be the majority of overdoses. I feel like fentanyl would certainly be the cause of the majority of overdoses likely. So I don't know if that the way that doctors are coding those is leading to it kind of misrepresenting what's actually happening there. I think that's a minor point, but maybe I don't know if it's worth having that breakdown if it's going to be confusing like that. And then I kind of agree with what Wendy had said about the looking at the heat map, and just trying to kind of compare those, where those hotspots are, where people are having overdoses in particular, to where are service providers, where are treatment programs, and then connecting those gaps with the mobile treatment and mobile kind of harm reduction, everything that's available, and seeing if there's kind of places where we might as a community need to say, like, hey, can we get somebody to start a treatment program in this area, or can we do something to engage people from this area where it doesn't seem like they're being engaged? So just really looking at the disparities again. I think that's a huge benefit for all this data and this dashboard that you have. And my last thought was just that we could, or I wonder, I think for me it would be interesting, and I think it's relevant to track engagement in MOUD, and ideally like broken down by methadone, buprenorphine by type at the county level, not just necessarily engagement for that small number of patients who were engaged with peer support, but like, is it possible to get the data from funders like Alliance or from treatment providers on number of patients that are engaged in treatment? I'm not sure exactly what the metric would be that would be the most useful, but just to have a sense of kind of like, are our efforts kind of as a whole with engaging patients at all these different sites across the county, are they actually helping us to increase our numbers of people who are engaged in treatment? And is that something that we could be displaying on the dashboard? I know that that wouldn't be like a specific funded initiative, but it might be that many of the other initiatives are kind of contributing to that. So just an idea. Thank you so much.
That's a great idea. I love that idea. I don't know exactly how to like navigate that, but I know Jason and I will probably work through on like who to contact and how to work through that. In relation to the toxicology data, I'm posting, it's in there and it's really small and it's italicized. That's kind of a pain, but I just put it in the chat of like how the counts and what they're based off of. So that's kind of all the data I have. But like I said, I'll reach out to NC Detect and see if we can kind of break that out a little bit, and then I can share everything back with Jason, and he can relay it to you all, or however you want to communicate about that. Thank you.
And Karen, I think is next, and then Paul. Do you have a comment or a question? Okay, we'll go to Karen next.
All right, thanks. I love all the comments, and this dashboard is I love data and being able to visually represent facts. Dr. Carter, I really like your idea about getting more contact information and also specificity of what sort of treatment options. I think, Brittany, you mentioned like what is being offered at these sites. I think if we added those two things in and then possibly got like a QR code that you could scan when you're at one of these sites, or you're going to one of the the distribution sites, that someone could be at one of the locations and scan the code and find the map to other places, so that it's really easily usable by people who are wanting to get to services quickly. If I'm at a place if I'm at a syringe place, can I also make sure I know where I can get other services? So.
Thank you.
And also John Paul, I was going to ask a question too about that as well, like coordination with the Partnership for Healthy Durham, both the Access to Care Committee and the Mental Health Committee. I know the Access to Care Committee publishes like a resource every year for folks who do not have insurance or who are underinsured, for like different places, safety net places in the community that they can go and access health care. And I believe the Mental Health Committee also is producing some type of resource guide for that as well. So I think those are also a couple of other groups that maybe we could work with as well for the resource material. But I wanted to ask about the demographic information around the current programs that are being funded. Is demographic information around the participants, is that being collected? And if so, is it possible to include that somewhere on the dashboard where you're tracking like the funding for the settlement funds and like what are the types of services that are being supported?
That's a good question. We're not really capturing demographics for the most part. I have harm reduction demographics that I'm not displaying that I could display for like new and returning individuals. So maybe that's something we could incorporate and we could kind of see what the breakdown is for unique participants. That's a really good idea, and that's something I should have obviously known to put on there. But that's something that I'll make sure is added within the quarter.
Thank you. Thank you.
Thank you very much.
Does anyone else have questions for John Paul? I know that a lot of questions, a lot of comments.
Well, I had one question. It may be a follow-up to what Dr. Carter was mentioning. It may be actually the question to her, which is, when we think about, methadone, buprenorphine, there's also different formulations of buprenorphine, and I don't know if, like knowing whether or not people administer Sublocade or have available Sublocade, because some of this might also help people decide where they might want to go. I'm just wondering, how specific will we be when we talk about the range of opioid support treatments.
You're saying like, should we put that type of information, like if Sublocade is available, for example, in the map for the resources?
Yeah. Or
Yeah,
wherever.
I think just trying to be as specific as possible about this is the treatment that's offered here. Call this person at this number to get an appointment, or walk in during these times, or what, however you access the treatment, and then something about cost. Ideally most things are hopefully covered financially, so there aren't financial barriers, but just like making that very clear so that people don't assume that maybe, I'm not gonna be able to afford this. Just having all that in the notes or something would be great.
And accepting insurance, sometimes that matters too.
Yeah, great point. Insurance, yeah, what insurance would be accepted?
Yeah. I mean, yeah.
That's a good idea. And that's easy to add as like a card at the top. So it's just like insurance accepted, Medicaid, Medicare, or private insurance. You can have an idea of what you're getting into. And we could even add a filter that could say like insurance type or something like that. That's a really good idea.
Yeah, because I'll tell you, when people call, they don't want to then go to a second or third. They want whatever they get, they want to know. We just know how this goes. So yeah, whatever we can do to help people be decisive.
Yeah, I think you also need to put self-pay in there as well. That there needs to be a specific category for self-pay. Third-party payers and whatever guise they come in. There are a fair number of them, which will probably change over the next couple of months, but it is what it is. But I think documenting self-pay required or self-pay made is another identifier of a high-risk population.
Well, just to qualify what Kay said, it could be also a sliding scale, because Lincoln, they do require some payment, but it is sliding scale.
And at Lincoln for MOUD visits specifically, there we have funding to cover the cost, so it's totally free. But yeah, I think that type of information is super useful.
All right. So we look forward to having you come back to meet with us again, John Paul. And I think there's a lot of interest in definitely like sitting down with you, learning more about the heat maps.
Yeah, I would love to do that. Yeah, anytime. Thank you so much. You guys have invigorated me and given me a really ample amount of ideas and stuff to pursue. So, Ms. Jacobs, I'm absolutely willing and able to help present any dashboards or show people the templates. So yeah, awesome. I really appreciate your guys' time. Thank you so much.
Thank you. Thank you so much. And so next on our agenda, we have some committee discussion. We're running a little short on time. The first thing we need to do, though, is review and approve our set of bylaws. And so Jason sent those out, I believe, in October. We can take a look at those and then go from there to see if we have any questions or need for more discussion about the bylaws, the proposed bylaws.
Okay, this is Kay, and I'll be the first bad girl to talk. I have not finished editing the bylaws. I would like to be able to do that. Well, one of the things that I would recommend that I couldn't find, and maybe it's because my brain is too scattered at the moment, but I would like to look at multiple documents, where on the website or in the document that describes what the chair people are to do, or what the mission of the committee is to do, and make sure that the description of who we are, what our specific purpose is consistent across each document using the same language, which I didn't see. And it may be that I'm just not reading it well and I need to spend some more time on it. And I'm sure that the fault lies with me and not with Jason, who did send it out with plenty of time, and I just haven't kept up. But the other thing, and this is going back to 60 years ago when I was a language student, when at the very beginning of the document, we talk about this group as a collaborative. And in my very old-fashioned mind, collaborative is an adjective. It is not a noun. So we may be a collaborative something. And, I went and looked at collaboratory, which is a relatively new word, and I don't think that's what we are. So if we could come up with a term that is a noun for a collaborative group of different kinds of interests and technical expertise that we have pulled into some constellation, that would soothe my English teacher heart.
Thank you. And I know that we need to also develop like our our mission statement and our vision and goals. How do other people feel about Kay's proposal that we maybe spend a little bit more time over the next couple of weeks, holiday season, and then we come back in January to get our bylaws together and make sure that we have our mission, vision, and goals also all consistent? I see some thumbs up.
I agree.
Okay, and Alonza, thank you, Alonza. And Dawn, your hand is up as well, or are you just giving thumbs up as well? Okay. All right. So I think
thumbs up.
thank you. So it sounds like we are going to just go ahead and like table this part of our agenda, and then we'll come back in January ready to discuss the bylaws, perhaps approve them, but also work on our vision, mission, and goals.
Okay, so Lisa, may I ask one more question?
Sure.
Once we get through editing and thinking about what's in the bylaws, what do we do with it? To whom do we send it? What poor soul will have the pure, unadulterated joy of reading 10 different versions of the same thing and trying to integrate them into a newly revised version? And then at that point, once we do, how are we going to put all of these brilliant ideas together into one document? And then are we going to sit down and review that again and then vote on them? I just don't get the process.
Yeah,
I need help.
Yeah, that's a good question. So a couple ways that I've seen groups do it. One is that we could all sit down and make comments, track changes ourselves, and maybe send them to Jason. He can compile them into one document and then send it out ahead of our meeting before we get back together in January again. The other is we can maybe even, Jason, is it possible to post them, like maybe on a Google document where everyone would have access to it, all the committee members, and then we could all make comments into one document? How would you suggest like we go through the process of providing comments and questions to the draft bylaws?
Yeah, thank you for posing that question. I actually kind of want to almost slightly defer that to I do have County Attorney Christy Malat on here. Almost a year ago, we started drafting these bylaws prior to any advisory committee being on board, just to kind of get us a kind of an initial start. So I don't know if Christy wants to add any comments, essentially for I think the question that's posed is how do we want to integrate everyone's comments, and is that putting on a SharePoint? Is that the best route that you feel, or do you have any recommendations or guidance, Christy?
Okay, hey guys, I'm trying to turn my camera on, but it's in safe driving mode from my drive home, so I'm sorry. Um, I think that you can either do them as track changes and we'll just compare them, or if you want to send a document and the bylaws should be each paragraph should be numbered so that you would find like paragraph 1A, and you could write what change you'd like to see for each one of those in an email. And that should keep it pretty simple for you all to make those changes, and then Jason and I can look through them.
How do people feel about track changes or sending questions or edits or suggestions via email? Or we could do a combination of both.
I'm okay with track changes and, sending it off. If we go to one of the Google spaces, somebody's going to have to teach me how to do that. I'm marginally trainable. I have one other specific question about the document before I forget. In that, when it said for voting for who would be a co-chair, it gave two options, but I don't believe it gave the option of a private vote, which is what I think I remember we did. So somebody needs to check that and make sure that if we want to allow, a private vote, then we make sure that the bylaws say that.
And sorry, this is Christy again. Because you are subject to open meetings laws in North Carolina, everything that you do needs to be in the open unless it meets a particular exception.
I understand that, which is why I'm asking, since I think, and God knows my brain doesn't work very well, that we actually did a private vote. We went on to some clever little document that Jason had put up, and we checked, we put X's or something on the candidates that we were voting for. And so Jason, help me out. Is that what we did?
So what I did was I shared my screen so that way those that were able to view it, it was open so everyone was able to see the results and everyone was able to see all the votes come in real time. I believe everyone should have seen that on their
Yes,
screens,
and so,
and
okay,
also those that were in the meeting as well.
we saw the
I'm sorry.
results, but that protected us as individuals from identifying which one of us voted for which candidate. And, what I would hope to see is that level of anonymity be protected, even though we very clearly show the results coming in. I just want to make sure that our ability to vote on what could be contentious issues would allow us the anonymity that we need to, more clearly express our real opinions.
Okay, I don't know that North Carolina state law allows for that. So Jason and I can talk about it. But I believe part of the concept of open meetings is that the public would know who votes for what. But Jason and I can look into it. I'll look into it and communicate with Jason about it.
Thank you very much. I come, as you can see, with a knowledge base of this kind of commitment of 0. So I need all the help I can get.
Thanks. And then we have Dawn and Brittany.
Yeah, my question on the bylaws, would it be more effective if the co-chairs maybe appointed like a subcommittee or something to look at or compile the responses or suggestions from the body as a whole and then try to come up with a document that's presented to the group, as opposed to the Google thing? I've been through the Google thing and it can be a mess and take a whole lot of time. And it could be 10 months before we have bylaws if we do it that way. Just a suggestion.
Yep. Is that something that is possible? I mean, And if so, who would volunteer to be part of that subgroup to just compile everything and then bring it back for the whole committee to look at?
I'll jump in again. I think that's I certainly agree with Attorney Baxton that that would make it much easier. Because you don't have bylaws yet, I don't know how you create a subcommittee without bylaws. I would say just start with sending an email to Jason with your requested changes. And if you feel more comfortable doing it as track changes, do that. If you feel more comfortable just writing paragraph 1A, change it to this, do that. And then we can figure it out from there.
Brittany?
Yeah. So I know we're running up on time. I just wanted to put to the group that because we meet relatively infrequently relative to like the amount of work that we hope to get done, and because we are not in the same room, I'm curious about how folks feel about having an in-person meeting soon. And then I would also love to float the idea of like obviously an open to the public like retreat where we have like a few out, like we take an afternoon or a day to really knock out like, you know, vote on the bylaws, develop a mission and vision, and then go into some of the nitty gritty of the strategic planning process to really be able to get this show on the road.
And perhaps January, February, beginning of next year. Is that also you? Okay. Karen?
I'm in favor of both of those things. I would love to meet all of you in person, those of you who I haven't met before. And I know that for me, I feel like there's a lot I need to understand about where money is being spent already, what commitments are already made, what's our goal, all that stuff. And I think that trying to do that an hour at a time once a month is it's gonna be a really long time before we get to any forward motion. So I'm in favor of that.
Since our next step is getting the bylaws together, how do y'all feel about maybe turning our January meeting into an in-person meeting? And maybe going a little bit longer than an hour and 15 minutes?
That sounds great to me.
So I see a couple of thumbs up, thumbs up. Is anyone not able to or wants to maybe think about another month?
Full disclosure for me, my daughter's having a baby next month, so I will be where I may not be here in person. I hope I won't be actually. But you all decide whatever works for the group. I just wanted to let you know, if all goes as supposed to go, I will not be here in person.
So I'm hearing next month we meet at our usual start time, but we go longer than 6:15 and we have it in person. Okay. And then to get ready for the bylaws discussion, since Christy and Jason have offered to compile our comments and our suggestions, our next meeting date is going to be on January 12th. Do we want to just agree on a deadline for when we will get our comments and suggestions to Jason and Christy? And if so, what date should that be?
Jason and Christy, do y'all have a preferred turnaround window for that?
Yeah, I mean, I'm in the middle of something right now, so I won't be able to look at it. I would say probably at the beginning of the new year without talking to Jason, but thinking about my workload, it would probably be the beginning of the new year before I could look at it.
Yeah, I think I'm around the same timeline, Christy, as well. So
You want to say? Oh.
No, go ahead. Sorry, go ahead.
Do we want to say January 5th before the 5th? Does that seem possible for folks?
Can we move it to like the 9th? I know I'll be out of town through the 7th, so maybe can we do January the 9th, that Friday?
January 9th, okay. So January 9th, we're all going to send in our comments, suggestions around the bylaws to Jason and Christy. And then on January 12th, we're going to meet in person at 5 o'clock, but have a longer meeting, and hopefully go through the bylaws and vision and mission perhaps as well.
And just to be clear, you'll send the changes to Jason, and then Jason can contact me and we can work on it.
That's right. Thank you, Chrissy. So our comments, our questions about the bylaws should be sent to Jason by January 9th. Okay. All right. So we are almost about close to our closing time. We had a really great meeting today, a lot of great discussion. We have some good next steps. Anything else anyone wants to share before we close out? Okay. Do we have to take a formal motion to adjourn? I think so. No? Okay. All right. Well, I hope everyone has a happy holidays, and I look forward to seeing y'all in January. Thank y'all so much.
Thank you, everybody.
Thanks, everybody.